hospitals of Pune city. The pre-intervention was conducted to assess the level of quality of life. Step 3, the selected interventions were explained to the selected samples. The samples were instructed on the use of explained intervention during the treatment phase. They could take their own time to understand. The time to intervene in the selected interview was around 60 to 90 minutes per session with clarification of doubts. The post-intervention test was to be conducted on the level of quality of life in 3 consecutive times on 15th day, first month and the second month among the selected participants. Step 5, the pre and post-intervention test data on the level of quality of life was computed for analysis and findings, interpretation of the findings. Analysis was mainly depending on 2 sections, that is, 1, frequency and percentage distribution of characteristics of participants based on demographic information. Section 2 compared the pre-test and post-test intervention scores on 15th day, 30th day, and 2 months of the quality of participants' quality of life. When we saw the analysis was done, it was found that 41 to 50 age group were 66%. Then the level of education maximum were SSC students, and the monthly income was more than 5,000 for the participant, that is almost 60%. Type of family was a nuclear family who experienced more of this cancer. Family history of cancer was a no from 13 patients, that is 86.66%. And questions was asked whether they received any information on nutrition, exercise, progressive muscle relaxation technique, but through yes and no, and it was said no. If yes, 53% said no. Found to be 17.3, and the p-value was 0.001, and that was found to be significant. The data represented that the calculated t-value was 17.34, as I said, and the p-value was less than 0.001. The result is highly significant, and you can see the quality of life scale used by me along with these nursing interventions has been more significant. Supportive studies were done, similar research studies were obtained, and you could see that 130 patients with breast cancer participated in the study. Just 99 women underwent post-assessment, and 14 women had the record suppressed after the intervention owing to death. The post-intervention study revealed statistically significant positive connection between the 4 quality of areas of life. Additional investigation revealed that at post-intervention respondent, quality of life had considerably improved in every dimension. The study found the quality of life had increased for every patient who had received support group intervention. Hence, hypothesis 1 is accepted and A0 is rejected. This suggests that there is such a significant enhanced high quality of life in post-test scores in the 2 months. Hence, the result interprets that the selected interventions are effective in improving the quality of life of women at the time of the treatment. Conclusion: the current pilot study results demonstrate the validity of researching a broad scale and indicate that specific intervention sessions were helpful. A few issues arose through the study's execution, including the need to follow up with participants and increase their confidence through phone conversations. However, this intervention was beneficial to individuals overall. These are the references. Thank you.
Thank you, ma'am. Thank you for your presentation. So now we are going to have the question and answer session. So if the participants or the judges have any queries, they can ask. So ma'am, what challenges did you face during the time of data collection and how did you overcome them?
My most important challenge which I faced during the time of data collection was that the patients who were supposed to be reporting back to me maybe on the 30th day and that after 2 months, some of them had some problem of not getting connection, internet connection, because I was recalling their answers back from phone, and that is through the video call also. And most of them also, there were two patients in my whole pilot study. They had said that they did not want to continue because they were not feeling well, out of which one of them said that they didn't want to continue the allopathic treatment, they wanted to shift on to the Ayurvedic treatment. So these are the two participants who were, so I had a problem of again getting newly diagnosed patient during the time of pilot study. That was my problem.
Yes. Okay, what are the next steps for the research in this area, or how can your study can be expanded or built upon?
My study can be expanded by identifying even the first step we take is screening of those newly diagnosed patients. And if the screening starts from the beginning, then you could come to the at least we could control this particular problem that the patients are having. And if at all the patients are having this problem, it is the need for them to continue the treatment and do not stop it at any cost, and try to be confident enough and go ahead. Because if they are not confident and if they do not believe on the treatment and keep their mind, they will not be able to face the problem.
Thank you, ma'am. Thank you for your presentation. Now it's time to call upon the second presenter number 2, Mrs. Swati Kurane, ma'am. Swati, ma'am, are you there? Kurane, ma'am. Okay, so we will move forward with our third presenter, Ms. Bhavisha Patel, ma'am. Bhavisha, ma'am. Okay. Is Neelam Patel, ma'am, available now? Neelam, ma'am, please unmute yourself.
Sorry.
Swati, ma'am, do you want to present now?
No voice.
Neelam, ma'am, please unmute yourself.
Yes, ma'am. I'm there.
Okay, Swati, ma'am is speaking.
Yes, ma'am.
Okay, ma'am, please start your presentation.
Yes, ma'am. Thank you so much. Can you see, ma'am? Hello.
Yes, ma'am, you can proceed.
Yes. So, myself, Mrs. Swati Kurane, Assistant Professor, Department of Medical Surgical Nursing, College of Nursing, Bharati Vidyapit, deemed to be University, Sangli, Maharashtra. So, I'm presenting here paper presentation, and my title is Attribution of a Disease and Disabilities Among Newly Diagnosed Leprosy Patients in a Sangli district of Western Maharashtra. In the introduction, I just want to say everybody knows that is leprosy is a communicable disease and infectious disease which can caused by the Mycobacterium leprae, and because of this, the main of this leprosy is a physical deformity, and due to the physical deformity in the society, we will have the stigma, discrimination, and overburden on the healthcare delivery system. And even though socio-economic problem is arising because of the leprosy patient. So prevalence rate in the India last year means 22 to 23. In that prevalence rate, India has reported 1 lakh plus more cases we can found it. So rising burden per year, that is more than 4,000 more cases than the previous year. So because of this COVID-19 pandemic area, many cases case detection be hampered because of the hidden cases are we can found it in the COVID-19 pandemic area. So government of India has launched one strategic national strategic plan as well as a roadmap leprosy in 2023 to 27. So this is the little bit introduction about my study. Objectives of my study are to determine the prevalence of disability among newly detected leprosy patients, and next, that is explore the clinical and social demographic characteristics of newly detected leprosy patients. So material and methods I have used, research approach is, that is quantitative, design is cross-sectional study, basically it is observational study. Research setting would be the Sangli district of Maharashtra, population adult leprosy patient in Sangli district of Maharashtra, sample newly detected adult leprosy patient registered in National Leprosy Eradication Registry of Sangli district. So sampling method I have been used here, non-probability purposive sampling technique, and sample size would be 55 and research period June 2023 to December 2023. So data collection and analysis of my study, I have used here pre-validated close-ended structured questionnaire as well as clinical characteristics which I can retrieve data from the National Leprosy Eradication Registry, which is present in the Sangli district in the Leprosy Center, and social demographic and environmental characteristics or variables I have conducted through the personal interview at the community level. So analysis I have done by frequency and percentage was I have used here. The results of my study here. Social demographic variables in that gender I have found mostly male patient 38, that is 69%, 69.1%, and age in mostly in a age group, that is age criteria is 31 plus 60. More I have found 32 patients out of 55%, 55 patients in that the percentage is 58.2%. So education wise, if you see here up to the SSC, I have found 43 patients are there, and percentage would be 78.2%. Residents is mostly I have found 42 patients in the rural area, that is 42%, 42 frequency and 76.4%. In the occupation wise, if you see here, I have found mostly daily wages patients, 34 frequencies are there and 61.8 percentage of that. And economically, if you see here, BPL means below poverty line. I have found out of 55 patients, I have found here 52 patients are there and 94.5 percentage are there. So here again, I have divided here a taluka wise distribution I have done here. In the Sangli district, we have 8 talukas, and in that 8 talukas, I have found Miraj taluka, that is out of 55 I have got 34 patients newly found in the Miraj taluka. So clinical features are here. Clinical features, type of leprosy according to WHO classification. Mostly I have found it multibacillary patients, multibacillary leprosy. The frequency are 44%, 44 and percentage are 80%. So subtype in that lepromatous, I have found 40 frequencies and 72.7 percentage of this. And then total number of skin lesions in that less than more than 5 skin lesions in the 36. I have found this 36 patients out of 55, and in that percentage is 65.5. Nerve involvement in nerve involvement, mostly ulnar nerve is involved in this case study. Then after number of nerve involvement less than 3 and more than 3, so which I have found here 43%, 43 patients, mostly less than 3 in that category. 43 patients I have found, and the percentage is 78.18. Duration of a nerve involvement is more than less than 12 months I have found 41 frequencies are there, and because of this, the 74% I have found it here. Again, the leprosy reaction, yes, no, in that criteria. So, just a minute. Frequency and percentage, yes, no. In 13 no patients, they don't have any leprosy reaction. And type leprosy reaction in the type 1 and 2. In that type 1, 5 patients I have found it, and type 2, 11 patients are I have found it, and the other patients, they have not applicable for the rest of the patient. So history of contact in that yes, no criteria, in that yes, I have found 30 patients, and the percentage are 54.5, 5%. Contact type within family, out of family, in that I have found within a family 25 persons I have found, and the percentage are 45.5 percent of them. WHO type of disability, there are three type of disability: grade 0, grade 1, and grade 2. In that I have found grade 0 25%, 25 patients I have found, and grade 1 25 patients I have found it. So the percentage are 45.5% are there. EHF score is there, that means eye, hand, foot score. So it is a categorized 0 to 4. So I have found it in the 0 category, 30 patients, and the percentage are 54.5 are there. And organs with disabilities means hand, foot, both hand and foot, and hand and foot, eye. So I have found here hand, foot, eye. Three organs are involved in this. So I have found 20 patients for the involvement of hand, foot, and eye. And the percentage are 36.4. So there are again the environmental factors assessment I have done here. So environmental factors, in that I have divided housing conditions, hygienic practices, and then environmental conditions. So in that means all this is all indirectly variables which can cause the leprosy, but not the full concentration of the leprosy patient. But these variables or these factors could be possible for to having a the leprosy condition. So here, just I think only overcrowding and hot and humid weather and insufficient drainage and poor ventilations, poor sanitation. Because of this environmental condition can cause the leprosy patients. So salient findings of my studies are in the demographic. Mostly I have found male patient age group 31 to 60 years from rural background and daily wages workers. In most I have found in Miraj Taluka and poor socio-economic and educational status. In the environmental factors or conditions, hot and humid weather, poor crowding, poor ventilation, and poor sanitation and insufficient drainage. Insufficient drainage I have found it there. In the clinical features, multibacillary leprosy and lepromatous subtype, and more than 5 lesions I have found it, and history of contact within.
Sorry for interrupting, ma'am. Ma'am, you're supposed to complete the presentation in 5 minutes.
Yes, ma'am. Finished. This is last one. Hand, foot, and eye involvement, and grade 0 and grade 1 deformity, ulnar nerve mostly involved in this case. The conclusion of this study, most of this is alarming number of multibacillary cases, organs involvement, deformity at presentation, and diagnosis and treatment delays is there. And so for that reason, I need risk factor analysis of this study. Thank you so much.
Thank you, ma'am. Thank you for your presentation. So what is the gap in the literature does your research address?
Can you repeat it, Megan?
What is the gap in the literature your research has addressed?
Madam, mostly prevalence rate of this of my study in 2020 to 2023, in that the more than we can means literature is supported, that is 1 lakh plus leprosy patients we found it. And during this COVID-19 pandemic, there is a between a gap, hidden cases are there. Hidden cases because we couldn't find because the COVID-19 conditions. So this is the biggest one gap, and because of this in Maharashtra, we found it 17,000 patients more in the Maharashtra case. In the Maharashtra.
Yes, ma'am. Is there any unexpected findings in your data?
Unexpected findings are made. This is the one of the which I have collected environmental factors. This is one. It actually it is very troubling for me because I have to go to every PSC, and the data may not be getting in a proper way because mostly what happened, mostly the patients are not there because some patients they are died and some means family members are there, so I am not getting a proper information in the at the community side. This is one.
Thank you, ma'am. Thank you for your presentation.
Thank you so much.
Now we'll move on to the third presentation. I'll call upon Ms. Bhavisha Patel, ma'am, to start her presentation. Bhavisha, ma'am. Please unmute yourself, ma'am. Okay. Yes, ma'am. You can proceed now.
Ma'am, before Bhavisa ma'am is presenting, I am Rupal Patel. First, I will do the presentation. Hello.
Yes, ma'am. You can start presenting.
Yes. Ma'am, myself Rupal Patel, Assistant Professor. So before Bhavisha ma'am is presenting, I am going to present.
Okay, ma'am.
Yes, ma'am. Sorry, ma'am.
Ma'am, already we are running out of time. Please start it on time.
Ma'am, PPT is not standing. Kindly please give me a minute. Is it visible?
Yes, ma'am. The screen is visible now.
Okay. Yes, thank you. So my study is a study to assess the effectiveness of isosaturation prior to intramuscular immunization in reducing pain among toddler in OPD in the selected hospital. Uh, Pain is measured to be to the almost approximate essence to be explained. Some healthcare professional pain is first experienced during childhood. So the Taxonomy Committee of International Association for the Study of Pain is defined. It is an unpleasant sensory and emotional experience associated with textual or potential tissue damage. Or described in terms of such damage, the American Pain Society created the phrase pain as the fifth animated sign to raise awareness of pain assessment between the healthcare experts, especially nurses. So the pain assessment is very essential to check the uh, level of pain in the toddlers. So the objectives of my study is assess the level of pain among toddlers receiving intramuscular immunization, assess the effectiveness of ICE application prior to IM immunization in reducing pain among toddlers. And the third one is to find out the association of level of pain with their selected demographic variable among the toddlers. So first I will assess the pain level of the toddler in intramuscular immunization. So I have selected pre-experimental quasi-experimental control group design. And in that, I have selected experimental group and control group. 30 samples I have selected. Hypothesis, there will be a significant difference in pain response after ice application prior to intramuscular immunization among toddlers. it is H1, and H2 is there will be a significant association level of pain with their selected demographic variable. So the methodology is design of my study is quasi-experimental, control group, post-test only. Approach is quantitative approach I have selected. Sample the toddler receiving intramuscular immunization in selected hospital. The sample size is 60 toddlers, where 30 toddlers in the experimental group and 30 in the control group. Sampling technique is non-probability convenient sampling. The studies outpatient department in selected hospital. So the tool for the data collection is there is two sections. Section is the demographic variable and section B is the flag scale. The flag scale, with the use of flag scale, I will assess the symptoms of the child according to that category. I have there are the score category is 0 no pain, 1 to 3 mild pain, 4 to 6 moderate pain, and 7 to 10 is the severe pain. So in the flag scale, there is a F means facial expression, L means leg, A means activity, C means plan, C means control ability. So that maximum score is 10 and minimum score is 0. The findings of my study is, first one is that to assess the level of pain among toddlers receiving intramuscular immunization. In this, it highlights that an experimental group, 6 toddlers come under the category of pain that having mild pain, 40 toddlers had pain that having moderate pain, and in control group, 30 toddlers had pain that having severe pain. To assess the effectiveness, second objective is assess the effectiveness of ice application prior to intramuscular immunization in reducing pain among toddlers. So, in that pain among toddlers in experimental group, the mean score on post-test was 3.2, and the pain level among toddlers in control group, the mean score on post-test was 8.13. Unpaired t-test value was 24.65, which was significant at t less than 0.05. Hence, the research hypothesis H1 is accepted. So it revealed that effective of ice application prior to IM immunization in reducing pain among toddlers. It is the third objective is to find out the association of level of pain with their selected demographic variable among toddlers. So the findings showed that there was no significant association between the ice application with their age of child, gender, religion, child past experience to immunization injection, mother's literacy level, and child reaction to health personnel at 0.5 level. So here I have completed my research study.
Thank you, ma'am.
Yes, ma'am.
Ma'am, how did you manage the potential risk or discomfort to the participants?
Ma'am, before doing this research study, I have taken the consent letter from the mothers and the parents. So I will, with the consent, with the request, permission of the parents, I have taken the data from the daughters.
Thank you, ma'am. Thank you for your presentation. Now I call upon the next presenter to proceed. Neela, ma'am, are you available now?
Hello. Good afternoon, ma'am. Ma'am,
Yes,
Bhavisha
ma'am.
is here.
Okay, ma'am, you can proceed, ma'am.
Ma'am, I'll start. Good afternoon, everyone.
Yes, ma'am. You're expected to complete in 5 minutes, ma'am.
Yes, ma'am. Yes.
Good afternoon, everyone. Myself, Bhavisha Patel, Assistant Professor in the Department of Mental Health Nursing in Sumandip Nursing College. First of all, thank you for giving me the opportunity to present my paper in your conference. So I'll start my presentation. So title of the study is Economical and Psychological Strain of Diabetes Treatment among people residing at Vadodara. So that need for the study, what is the need of this study? So diabetes is one of the most prevalent chronic disease in the United States, and a leading cause of that estimates based on 1993 National Health survey indicates that diabetes has been diagnosed in 1% of US population age. Studies show that diabetes are at increased risk of developing psychiatry, 10 to 20% for eating disorders, 8 to 30%, as well as substance abuse, 25 to 50%, leading to non-compliance with treatment and deterioration of diabetic control. At high risk are female adolescents with family problem and other comorbid disorders. In fact, cognitive function has also been reported among children with diabetes, mainly in boys and especially in those with early diabetes diagnosis or with episode of severe hypoglycemia or prolonged hyperglycemia. So objective of my studies are assess the economical and psychological strain diabetes mellitus person who are under treatment. Second one is find out the association between level of economical and psychological strains with selected demographic variables. Hypotheses are there will be significant association between level of economical and psychological strain with selected demographic variables. Research methodologies approach was exploratory research design of design place of study urban and rural areas of Vadodara. Sample consists of persons who are taking treatment for diabetes. Sample size 50% with diabetes. Sampling technique, obviously sampling technique. Tools are divided into three areas. First one, demographic data. Part two, that is expenditure details of the sample. Is emotional strain assessment. The data for main study was collected from 50 patients of undergoing treatment of diabetes mellitus, those chosen after away from urban and rural areas of Baroda, villages, Amur, Victoria, and Mumbai. Fulfill the inclusive criteria expenses of the sample and emotional costly versus economic and psychological strain of diabetes mellitus person who are under treatment. Data for pilot study tentatively was collected from different places that of main study from among 10 patients. Consent was taken from participant and they were assessed using expenditure details of the sample and emotional strain assessment questionnaire. The description of emotional strain assessment questionnaire was comprised of 16 questions. The results are so frequency of psychological stress, so majority are from psychological state at 4%. Peak of psychological stress is 42.20 standard deviation is 9.66. So association, I didn't found any significant in association between psychological strain and socio-demographic variable. There is no significant association with demographic variable. So summary finding of the study conclude that majority of participants reported psychological strain, although the study did not find any significant association between psychological strain and the selected socio-demographic variable.
Ma'am, you can proceed.
Hello.
Hello, ma'am. What inspired you to
Yes,
choose
ma'am.
this research topic, ma'am?
Ma'am, I'm not getting your question.
What inspired you to choose this research as your topic?
Ma'am, actually, so many persons are suffering from diabetes, and even also my family members in my family history, so many are having diabetes. So, and many research study I have gone through that. So many diabetic and psychological strains. So many persons are suffering from that. So because of that, so I've chosen the topic.
Okay. So what new findings that your study has given in the field that we have already known in this area?
What, ma'am?
What new knowledge your study has given to us, as we have some idea regarding diabetes and this all these things. So I want to ask is, what is the specific thing you found out?
Ma'am, there were moderate psychological strain. The person with diabetes are suffering from, ma'am.
Is there any
Mod-
unexpected results or findings?
no, no, ma'am, no, ma'am.
Okay, ma'am. Thank you for your presentation. We will move
Thank you,
forward
ma'am.
with the next presenter.
We'll continue with this, ma'am.
Yes, Bhavisha ma'am.
Yes, ma'am.
Please proceed, ma'am.
Hello. Hello.
Yes, ma'am, you're audible. You can start.
Yes, ma'am. Yes. Good afternoon, ma'am. Myself, Neelam Patel, MSc Nursing tutor from the Sumandeep Nursing College, Vadodara. The presentation topic is comparative study to assess the knowledge and attitude regarding menopause and its management among the rural and the urban women of Ahmedabad city, with a view to develop an information booklet on it. Is the need of this study? Women all over the world now have to spend almost 1/3 of their lives in a menopausal year. Therefore, menopause now it is a concerning matter to maintain and improve the woman health. Most of these women experience both the physical and the psychological symptoms. Thus, it is important that women during the menopausal periods should have adequate knowledge regarding the menopausal symptoms, and that may enable them to accept the inevitable changes and loss and recognize the qualities and the capabilities. Objective of this study: assess the knowledge regarding menopause and its management among the rural and urban women of Ahmedabad city. Assess the attitude regarding menopause and its management among the rural and urban women of Ahmedabad city. To compare the knowledge and attitude regarding menopause and its management between the rural and urban women of Ahmedabad city. To find out the correlation between the knowledge and attitude regarding the menopause and its management among rural women of Ahmedabad city. To find out the correlation between the knowledge and attitude and its management among urban women of Ahmedabad city. There will be a poor knowledge and the negative attitude regarding menopause and its management among rural women of Ahmedabad city. There will be good knowledge and the positive attitude regarding menopause and its management among urban women of Ahmedabad city. There will be a good knowledge and a positive attitude regarding menopause and its management among urban women as compared to the rural women of Ahmedabad city. There will be a negative correlation between the knowledge and attitude regarding menopause and its management among the rural women of Ahmedabad city. There will be a positive correlation between the knowledge and attitude regarding menopause and its management among the urban women of Ahmedabad city. Research methodology, research approach, descriptive survey approach, research design, comparative survey design was used. Variables, study variables and the socio-demographic variables, research setting, selected urban and rural area of Ahmedabad city. Sample size, total 200 women, including 100 each of rural and urban area. Sampling technique, non-probability purposive sampling technique was used. Data collection technique, structured knowledge questionnaire and Likert attitudes was used. Reliability of the was tested using the split half method. Reliability score for the knowledge questionnaire was the 0.805 and the attitude scale was 0.892. Process for the data collection. Investigator selected the samples by using the non-probability sampling technique. The investigator explained the purpose of the study and information booklet was provided to the woman. Analysis of the data. Recorded data is master demographic analysis, frequency and the percentage. Knowledge and attitude score for the menopause and its management in form of the mean, median, standard deviation and the mean percentage. This table is the frequency and the percentage-wise distribution of the sample based on the demographic variable. Mean, median, mode, range of standard deviation of the knowledge, the rural and the urban woman. Rural woman standard deviation is 2.55 and in urban women 2.47. Mean median mode and standard deviation of the attitude score in a rural woman 3.03 and urban woman 3.86. Comparing of the knowledge and attitude regarding the menopause and its management between the rural and the urban woman. Between the rural and the urban woman, p-values is a 10.029 and the p-value is 0.001. In attitude level, t-value is 8.371 and the p-value is 0.001. So correlation between the knowledge and attitude among the rural and the urban women is a level of significance 0.05 level, and same correlation between the knowledge and attitude among the urban women is a 0.05 level. Summary: the main knowledge score of the urban woman is 12.43 is greater than the main knowledge score of the rural woman 8.86. The mean attitude score of the urban woman 22.19 is greater than the mean attitude score of the rural woman 18.08. There is a significant difference between the knowledge level of the rural and urban woman, and there is also significant difference between the attitude level of the rural and the urban woman.
Thank you,
There is a
ma'am. Thank
moderate
you.
positive
Thank you.
correlation knowledge
Thank you,
and
ma'am.
attitude regarding.
What gap in the literature does your research address?
Because ma'am, nowadays in a rural areas, women not that much knowledge regarding the menopausal management, how to manage the sign and symptoms, and so many reviews and literatures are referred.
Okay, what challenges did you face during the time of data collection, and how did you overcome them?
Specific in rural area, some women them and give the information booklet and pass out the information and to motivate regarding the what is the how to reduce the menopausal symptoms.
Okay, is there any unexpected findings, ma'am?
No, ma'am.
Okay, ma'am. Thank you for your presentation. Now I'll move
Okay.
forward and call upon
Thank you, ma'am.
Ms. Seetal Power to present for the presentation. Sheetal ma'am, are you available now? Sheetal Power ma'am. Okay, we'll proceed with the next presenter, Ms. Nikita Wagh ma'am. Nikita ma'am, can you present now? Okay, I call upon the presenter number 8, Mrs. Sadhana Shinde ma'am. Sadhana ma'am. Okay, Sheetal ma'am is available now. Ma'am, you can unmute yourself.
Hello.
Yes, you can proceed.
Hello. Am I audible, ma'am?
Yes, you can proceed, ma'am.
Okay. Should I share my screen, ma'am?
Yes.
Is it visible?
Yes, ma'am, you are visible and you can proceed now.
Okay, madam. Okay. Good afternoon, respected judges. Here, myself, Sheetal Pawar, PhD scholar from D.Y. Patil College of Nursing. And my research topic is effect of modified Bradley birthing interventions on birthing experiences among primary mothers in selected hospitals. So, for this, the objectives I stated such as to compare post-observation of birthing experiences between experimental and control group among primary mothers, then to find out association of the selected demographic variables with birthing experiences and pregnancy outcome among primary mothers. Hypothesis. H1 hypothesis is there will be significant difference between post-test birthing experiences of primary mothers in experimental and control group. Then hypothesis 2 is there will be significant association between post-test observation with the selected demographic variable in experimental and control group. Then first I need to explain what is actually the Bradley birthing intervention and what modification I made in this. So the birthing intervention which mainly given in this Bradley birthing techniques is related to the antenatal intervention and childbirth intervention. So firstly the Bradley birthing intervention is that is preparation for the labor for the mother. So it's specially started when the antenatal period is started, and in that also the last month of the the mother pregnancy. So in that it's actually gets started. In that it actually gets started. In that the antenatal interventions such as
Ma'am, your voice is breaking. Sheetal ma'am, we lost your audio.
hello.
Yes, now you're audible.
Should I explain again, ma'am?
No, you start from here.
Okay. So actually the modified Bradley birthing intervention means what the mainly we are preparing the mother for the pregnancy. So in that it is divided into antenatal intervention and childbirth intervention. So mainly the antenatal intervention such as care and nutrition, then antenatal active exercises, relaxation technique, meditation and yoga. Whereas childbirth interventions are control breathing exercise, pelvic rolling exercise, then changing position, back massage, which makes her labor without undue complications. So mainly the childbirth interventions are specially giving at the time when the mother is in pre-labor state. When the sign and symptoms are get started, that is true labor pain whenever get started, that time only we are providing this intervention. Then the conceptual framework I prepared where I used the Troy's adaptation. So through that, the stimuli I specially present in the studies are that is knowledge regarding labor process and role of husband in the childbirth. Then contextual is that is anxiety, perception level and the unknown experiences. Whereas residual means age and education will be there. Then the next coping mechanism where implementation of Bradley birthing. So here mainly she is going to adapt this thing. So that's why Roy's adaptation model. That's why I took this the concept over here. Then next is physiological function, then role function, self concept and interdependence function. This I am going to assess through the implementation of Bradley method. Then the next I'll take the output of this, that is stimuli. I'll observe over here, that is knowledge regarding labor process and with the role of husband during the childbirth. Then contextual in that anxiety, then perception level and unknown experiences, and residual in that again I'll check the age and education, is there any effect is present or what. Then regarding research methodology, in that research approach I use that is quantitative research approach, and the research design is that is true experimental post-test only control group research design. So only the post-test I'm going to assess over here. Then next is population. So that is target population is all primary mothers admitted in hospital. Then accessible population is all primary mothers who fulfill the inclusive and exclusive criteria. Then study setting is primary mothers in antenatal ward in selected hospital. Then next is variable. So in that variable, that is dependent variable. And
excuse me, ma'am. Sorry for interrupting. You're running out of time. Please summarize your topic.
It's going. Okay. So mainly regarding the data analysis interpretation. So first objective was that is to compare the post observation of birthing experiences between experimental and control group among primary mothers. In that the H1 hypothesis I use over here, that is there will be significant difference between the post test birthing experiences of primary mothers in experimental and control group. So the calculated T value is higher than the table value and P value is less than 0.0505. So therefore the H1 hypothesis was accepted, and with this also the we are saying that the objective is also get accepted. Then the next one is to find out the association of the selected demographic variable with the birthing experiences and pregnancy outcome among primary mothers. So here the H2 hypothesis is also there for it. That is, there will be significant association between the post-test observation with their selected demographic variable in experimental and control group. So while showing association between age and childbirth experiences, as our p-value is 0.02, which is less than 0.05, so the association is significant. Then while showing association between body build and childbirth experiences, the p-value is 0.15, which is more than 0.05. So the association is again insignificant about the body build. Then while showing the association between the education and childbirth experiences, as our p-value is 0.96, which is also more than 0.05, the association is insignificant over here. Then while showing association between antenatal exercise and childbirth experiences, the p-value is 0.02, so which is less than 0.05. So the association of antenatal exercise is completely significant for the collected data. So according to this, I can say that the Bradley birthing technique is effective for provision during the antenatal and childbirth, and which gives the effect that feedback I am getting that the at least mother is stressless during the labor, and the outcome will be mostly the mothers are getting towards the normal labor and delivery.
Thank you, ma'am. Thank you for your presentation. Time question answer session. So how
Yes,
can
ma'am.
you study impact future research, clinical practice or educational practice?
Impact is, ma'am, this be when we are going mainly when we are posting the student into the during the obstetrics and gynecological posting in the clinical side. So that time it is useful that the patient and direct patient student impact will be there, or communication will be present, and student can able to educate the patient accordingly.
Okay, ma'am. Thank you for your presentation. Now we call upon Ms. Nikita Wag, ma'am, for the presentation. Nikita, ma'am, you can present now. If Sadhana ma'am is available, she can present. Okay, Nikita ma'am has arrived. Yes, ma'am, you can proceed. Nikita ma'am, please unmute yourself. Nikita ma'am, your screen is visible, ma'am. Please unmute yourself.
स्क्रीन is visible. तुम्ही नाव काय आहे तुमचं याच्यामध्ये नाही आम्हाला तुम्ही जॉईन केलं ना त्याच्यातून टीचर साधना शिंदे. बरोबर हां झालं. शेअर झालं.
Good afternoon, madam. Myself Nikita Wagh. I'm PhD scholar at DY Patil College of Nursing, and my statement is effect of oral motor interventions on cooling among cerebral palsy children at selected centers of the city. My objectives are to assess the drooling among the cerebral palsy children in experimental and control group, and second is to assess the effect of oral motor interventions on drooling in experimental group. About the current scenario, so cerebral palsy is one of the movement and postural disorder again which is affecting the child's speech. Again, drooling is there typically. Child is also having the drooling, that is 10 to 13% of cases, as well as the to develop the awareness and strength as well as coordination and movement of the lip, cheek as well as tongue and jaw. About the hypothesis, my research hypothesis is, null hypothesis is, there is no effect of oral motor interventions on drooling among cerebral palsy children after administering the oral motor interventions. Methodology, I have selected quasi-experimental, non-randomized control group design, and 4 to 12 years of children were included. Non-probability sampling was used, and different kinds of rehabilitation center were involved in this. And 10 sample I have enrolled, and in which 5 were from experimental and 5 in the control group. About the inclusion criteria, I have included 4 to 12 years of age group children as well as those are having the cerebral palsy with all types of cerebral palsy with affected with the oral motor skills. In exclusion criteria, I have included all the non-cooperated children were excluded, as well as those were having the neurological problem, congenital deformities like cleft lip and cleft palate, as well as deafness and blindness were excluded, as well as those are having any kind of critical condition. Reliability were calculated with the help of iterated method, and Cohen's kappa was used for calculation of R value, and that is plus 0.82, and that the tool is reliable. About the operational definition, so about the definition of oral motor intervention, so first is pressure. So here pressure is applied on the both the cheeks towards the lip for the 10 times. Pressure is applied on the tongue for the 10 times. Again the lower jaw on the 10 times. Pressure is applied on the lower lip for the 10 times. Second was the tapping. Again the tapping was done on the cheek, outer side of the lower and upper gums. That was for 5 times. Then stroking was done.
Madam, we have lost your audio. Madam?
Ma'am, my PPT is not visible.
No, your PPT is visible, ma'am. Now your audio has also been resumed. You can proceed, ma'am.
Yes, ma'am.
1 minute is left, ma'am. Ma'am? Are you available?
PPT is not visible for me. Stop sharing करते हैं.
Ma'am, just discuss the main findings, ma'am.
This is about my demographical variables. And in study findings, first objective to assess the oral motor skills among the cerebral palsy children in experimental and control group, in which in experimental group 80% of cerebral palsy children had mild oral motor skills and 20% of them had severe oral motor skill. In control group, cerebral palsy children had mild oral motor skills and 60% of them had moderate motor skill. In second objective, to assess the effect of oral motor interventions on selected oral motor skills in experimental group, in which experimental group in pre-test, 80% of cerebral palsy children had mild oral motor skills and 20% of them had severe oral motor skills. In post test, 60% of them did not have the drooling, and 20% of them have the mild drooling, as well as 20% of them had moderate drooling. This indicates that the drooling among the children improved after the oral motor interventions, in which I have used the t-test, and the average drooling score among the cerebral palsy children in the pre-test was 5, which was reduced 3.4 in the post-test, and the t-value for the same is, again, it is less than 0.05, and that only indicates
Thank you, ma'am. Thank you for
oral
your
motor
presentation.
interventions are significantly effective on reducing the drooling among the cerebral palsy children.
Thank you, ma'am. How did you manage the potential risk or discomfort to your study participants?
Actually, ma'am, can you speak
How
again?
did you manage the potential risk or any complication to your study participants?
Actually, complications will be, ma'am, while doing the study, many times it was difficult for me to handle those children, ma'am, as they are very, like, they are having the cerebral palsy. And first, actually, I faced problem is during the speech therapy. Only in between, I used to go and do all these exercises. So many times the children were not cooperating. And later, I have planned separate session for them, and later I did the study.
Okay, ma'am. Thank you for your presentation. Now I call upon Mrs. Sadhana Shinde, ma'am, for the presentation. Sadhana, ma'am, are you available now?
Yes, ma'am.
Yes, ma'am. You can proceed. All. My name is Sadhana Sudhir Shinde, PhD scholar from DY Patil College of Nursing, Pune. The statement is effectiveness of emotion-focused cognitive behavioral therapy on self-esteem among adolescent girls with eating problems from selected junior colleges. Introduction. Eating problems and low self-esteem commonly co-occur among adolescent girls exhibiting mental health concerns. Self-esteem is prevalent among teenage girls, increasing the risk of mental health issues. Eating problems, including emotional avoidance of food due to fear of weight gain and binge eating disorder, are prevalent among adolescent girls. This disorder often co-occur with low self-esteem. This study investigates the impact of emotion-focused cognitive behavioral therapy on self-esteem among adolescent girls with eating problems, and the prevalence rate of eating problem among adolescents in the study conducted at Mangalore suggests that 31% of the adolescent girls were having high risk of eating problems. Objective: to assess the effectiveness of emotion-focused cognitive behavioral therapy on self-esteem among adolescent girls with eating problems. Hypothesis: null hypothesis, there will be no significant effect of emotion-focused cognitive behavior therapy on self-esteem among adolescent girls with eating problems at 0.05 level of significance. An alternative hypothesis: there will be significant effect of emotion-focused cognitive behavior therapy on self-esteem among adolescent girls with eating problems at 0.05 level of significance. Methodology: research approach, quantity approach, and research design. Quasi-experimental research design. The study setting is selected junior college, and non-probability purposes sampling was used. Population: adolescent girl from selected junior college and adolescent girls who met the screening criteria made by researcher, that is EAT scale score more than 20 and height and weight with standard measures. Sample size 30, as it is a pilot study, and in tool demographic variable EAT 26, which is standardized screening tool for eating problems, and Rosenberg self-esteem standardized scale was used.
Operational definition here, emotional focused cognitive behavior therapy consisted 29 days of weekly session focusing on psychoeducation, emotional regulation, and cognitive restructuring with self-affirmative exercises and eating problems. It is a deliberate avoidance of food due to negative emotion associated with body, self-image, and low mood due to fear of weight gain present among adolescent girls. And here the adolescent girls are who are 16 to 18 years of age. Procedure, the sample recruited 30 adolescent girls aged 16 to 18 with eating problem from selected junior colleges. The adolescent girl who weighed below the standard for height and the eating attitude scale 20 scale scores of more than 20 were assigned to the experimental group and control group. Self-esteem was assessed using standardized Rosenberg self-esteem scale, and participants were randomly assigned to emotion-focused cognitive behavior therapy for 15 sample for experimental group and 15 for control group. And here result findings in experimental group pre-test for 15 sample, mean score is 21.20 at standard deviation 2.76, and post-test score, the mean is was 29.20, which is increased, and standard deviation is. Conclusion, the pre-intervention level of self-esteem was 21.20 with standard deviation 2.76, and after the intervention, the mean score increased to 29.20 with standard deviation of 0.68. The pair test value was 9.47 and the p-value was less than 0.5, indicates a significant effect. This suggests that the emotional focused cognitive behavior therapy techniques impacts the health self-esteem level among adolescent girls from the experimental group. Thank you.
Thank you, ma'am. Thank you for your presentation.
Thank you, ma'am.
What was the most challenging area or aspect during the time of your data
While
collection?
data collection, the most challenging aspect was giving emotional focused cognitive behavior therapy because of low response from the adolescent girls. Then home assignment, there is completion of home assignment which is given to the adolescent girl, like affirmative exercises, reconstruction of the thoughts, and students needs motivation.
Yes. So how did you handle the missing data in your study, ma'am?
As such, there is no missing data, ma'am.
Okay.
I first take a prevalence of eating disorder, which is 27% in India. That is these eating problems, and after that only only that sample I collected emotional focused cognitive therapy intervention.
Okay, ma'am. Thank you. Thank you for your presentation. So, and I call upon our ninth presenter, Mrs. Shilpa Bagal, ma'am, to present her topic. Shilpa, ma'am, are you available now?
Yes, ma'am, I'm there.
Yes, ma'am, you can proceed now. Your voice
Yes,
is audible.
ma'am. Yeah. Good afternoon, everyone. Is my screen visible?
Yes, ma'am, your screen is visible
Okay.
now.
So the title of my study is to assess the problems among patients with celiac disease in selected hospitals of Maharashtra and explore the interventions currently adopted for their management. So celiac disease is defined as an autoimmune disorder which is originated by the immune response with the gluten which is contained in few of the grains. So it is a complex immune mediated disorder, one in which the immune system causes damage to the small bowel when affected people eat the gluten. People with celiac disease may experience variety of symptoms starting from mild diarrhea, bloating, gas, anemia, and it may go up to the Crohn's disease, which may be most of the time remain undiagnosed, and it is differentially diagnosed as GI disorders, but it will be a celiac disease. So it's a qualitative study, and I have two objectives for this study. First one is to assess the problems among patients with celiac disease. Second, to explore patients who are health professional. Sample size, as I have adopted the interview method for the data collection, so my sample size remain up to this data saturation. Sampling method I have used is purposive sampling method, that is multi-phase sampling. So overview of my data collection process, I have taken written and audio consent. Participants were informed that the audio tapes of the interview would be held confidential and would only be heard by the transcriber of the tapes. Demographic data is collected. I use semi-structured interview method throughout my interview. These face-to-face interviews were recorded using an audio recorder. Duration of the interview varied for one participant to the other from 45 minutes to 1.5 hours. All the interviews were conducted in the clinics. The interviews were conducted in 3 to 4 sessions. I have taken the field notes during the interview itself. The field notes included notes related to participants' body languages, their emotional expressions, and important factors coded by them. After the interview, verbatim was written after listening to each audio recording several times. So this is about the demographic data. I'll be displaying only the final conclusion of demographic data. So this is the summary. 16.7% of the patients with celiac disease were in the range of 25 to 45. So maximum is in the 46 to 65 years old. 50% of them were males. 67.7% of them were married. 50% of them had secondary education and 50% were graduated. The maximum numbers of the patients were having the occupation of clerk. 50% of them had monthly income from 15,000 and 16.7 had monthly income up to 25,000 and 33% up to 25,000 to 35,000. Most of the patients, they had a health habit of consumption of alcohol. Now my second objective analysis, that is in-depth interviews which were semi-structured, which I have collected up to the data saturation. Now the data saturation had occurred after 24 samples, and then the repetition of the themes and sub-themes were observed. So the thematic analysis of the data, this section deals with the analysis of the data collected through face-to-face interviews from the patients from all over the Maharashtra. The data gathered was written down in the verbatim form, translated into the language understood by the patients, and then the transcript was read back to them, read by them again to establish credibility/validity of the data. The terms used by the patients to describe the problems and interventions adopted by them were analyzed through qualitative analysis. I have identified every atom or word expressed by the patients to formulate themes which could further be explained into the experiences under various titles. Interviews and field notes were analyzed and essential meaning was presented in terms using according to the context as described by the participant. The interview or field notes transcripts were read thoroughly and completely to derive meaning to the experiences shared by them. Rereading was done to ensure the data was further divided into smaller elements to strengthen the finding. Findings were elaborated with the help of the terms and references collected from the interview/field notes. Interpretation were justified with essential meaning in the form of quotes to generate the themes. So this is the overall qualitative analysis. So it is themes. Is it visible, ma'am?
Ma'am, it is visible.
Yeah, so themes, sub-themes, and the codes. So the themes were symptoms. Into that, sub-themes are concentration, energy, and gastrointestinal pain. And the codes are mood changes, irritability, headache. For energy, it was tiredness, could not go out of the home, look pale, patients having ulcers in the mouth, bone pain, GI system, pain in the stomach, or pain after lunch or dinner, acidity, loose motion, feeling of vomiting, and constipation. Second theme was gluten-free diet, and the sub-theme was acceptability of gluten-free foods. So in the quotes were salads, fruits, avoid grain, avoid bakery products, diet chart. Second sub-theme, cross-contamination. So in that, patient expressed their fear of cross-contamination in the statements, that is careful about mixing of the food with gluten content, eating outside the home.
Sorry
very
for
careful.
interrupting, ma'am. We are running out of time.
So
how can your study impact the future research, clinical practice, or education practice, ma'am?
Yes, ma'am. So Ma'am, on the basis of this data, as the celiac disease remains undiagnosed, or it is most of the time it is having a differential diagnosis, so the patients will face so many problems, and it's a gluten sensitive disorder. So on the basis of this qualitative data, the further tools can be developed for the assessment of the celiac patients.
Okay, based on your findings, what recommendation do you have for policy, practice, or for future research?
Yes, ma'am. As my findings have 7 themes, 23 sub-themes, and 70 candidates items, which clearly says all the factors which the patient may face because of the celiac disease. So, modification in the health assessment or history collection or during the GI assessment can be done on the basis of the findings.
Thank you, ma'am. Thank you for the presentation.
Yeah, thank you so much, ma'am.
And now we call upon Dr. Shweta Joshi, ma'am, for the presentation. Madam, are you available now?
You can hear me?
Yes, ma'am, you're audible now.
Good afternoon, everybody. Myself, Dr. Shweta Joshi. I'll be presenting my research on effect of physical exercise on child well-being during COVID-19. As we all remember, the COVID-19 outbreak had rapidly become a global health threat, and the impact was observed morely on children's health. The studies has observed that during COVID-19 pandemic, children's screen time had increased and the physical activity has reduced. The physical inactivity is now identified as fourth leading factor in global mortality. Engaging in physical activity from young age has been linked with reduced risk factors such as chronic diseases, obesity, diabetes, and hypertension. It has also indicated that physical activity associated with reduction of symptoms like anxiety, depression, the mood regulation, and improved self-esteem and cognitive function. So the objective of the studies were to assess the physical and mental well-being of a child, to assess the effect of physical exercise on physical fitness and mental well-being of a child, to find the association of physical fitness and mental well-being with selected demographic variables. The null hypothesis, the alternative hypothesis was physical exercise has a statistically significant effect on child well-being, and there is association between between the child well-being and the demographic variable. The methodology adopted was evaluative approach. The design was pre-experimental, one group pre-test, post-test design. The samples were from 12 to 14 years of age group. There were 100 school children selected, and the technique was used as purposive non-probability sampling technique. The settings were 2 schools of PCMC. Content validity was done with 15 experts, and the reliability method was used as inter-rater method. The pilot study was conducted with 10 samples, and it showed that the study is feasible. The tool was divided under 4 sections: demographic data, which consisted of 15 items. There was observation checklist, which was prepared to assess the physical fitness. Modified skid screen test was done to assess the child's mental well-being. The profile of physical exercise was explained in detail, as the physical exercise consisted 10 minutes of warm-up, 30 minutes of exercise, and 5 minutes was given for Shavasana to cool down. The data collection process, the samples were recruited through WhatsApp group, which was done with the help of school teacher. The Google form was created and it was been sent to the participants, and based on their eligibility, they were selected. The samples attended a virtual meeting via Zoom. At the meeting, the researcher explained, demonstrated, and also took the re-demonstration from the children. The post-test was conducted on 6th day, 12th day, 18th day, and 24th day. The ethical approval was taken from the institutional ethical committee. The result, the demographic statistic, basically, if you see, the majority of the children were from the age group of 12 to 13s. Most of them were 53% females, and their parents had graduation degree. To see other variables, the sleeping pattern was observed that 41% had sleep less than 6 hours, and even the majority, like 64, had good health, normal weight, still 36% children were identified as overweight, and 47% of the children had indoor activity less than 1 hour. To go to the second objective, it shows that the effect of exercise on physical fitness. So on pre-test, it was observed that 34% of children had poor physical fitness, 49% had average, and it was 17% who had a good physical fitness, which gradually improved from 49 to 52% in day 6, and on day 12 it was improved from 17 to 18% as good, and on 18th day it was improved to 20% as a good, and you can see on day 24th the maximum children were having average physical fitness, and there were 10% who shifted in an excellent fitness score. To see towards mental well-being, it has been influenced the mental well-being of a child. As you can see in pre-test, only 3% had a poor mental health and 86% had average, which gradually improved to day 24 to 99% who had good mental well-being, and only 1% were in average mental well-being. Now, consistently, you can see there was an improvement in the physical as well as mental well-being. The pair t-test was used, which showed that the mean test of physical fitness, which was 9.7, which improved to 11.48. And in mental health also, the mean score improved from 26.75 to 31.75. The Fisher exact text was applied to identify the selected demographic variables, and it was found that there was association with age, gender, BMI category, sleeping hours, indoor activity. These were the demographic variable where there was association with physical fitness and child well-being. The discussion, the present study showed that average physical fitness score was about 9.7, which increased to 11.48 on day 24th. Similarly, there was study which shows the effect on improvement of virtual program of exercise, and it was an 8 weeks program, and they also had increased physical activity level with the self-determination index. There were other 2 studies also had shown the similar efficacy effect of exercise on physical parameter. Secondly, if you see the pre-test also 3% had a very poor mental health, and there was an online survey done by Leo which also showed that 12.33% had depression, whereas 6.26% had anxiety. The mental well-being from pre-test, as it is improved from 26.75 to 31.75. Similarly, there has been notable improvement in mental health scores in participants following the exercise intervention. There was a systematic review and meta-analysis was also conducted, which showed that the regular physical activity can support the mental health of a child. Even in demographic variable, like there was a study done by Gavin which showed that 24% of children achieved, only 24% achieved the recommended level of physical activity, and it was more in boys compared to girls, where I also had found in the gender that it was more in boys than compared to girls, and there is an increased sleep problem during pandemic compared to before pandemic. To limit, there were some limitation for my studies, such as the participants were minor, so maybe data may not be reliable. Even the sample size was comparatively less, so these were some limitations. To conclude my study, this study reveals that the positive impact of regular physical activity on both physical and mental health of a child can be helpful for the child. Significant improvement in physical fitness and mental well-being were observed over a period of time, that is on 24th day period, and these findings emphasize necessity of promoting physical exercise among children to enhance their overall health and the quality of life. To acknowledge my study, I want to be thankful to management of Dr. Divya Patil Vidyapit, as this was my funded project. And we also want to thank the school administrator, parents, the samples who has enthusiastically participated in this study. Thank you so much.
Thank you, ma'am. Thank you for your presentation. How can your study can be expanded or built upon?
The study can be done as a long term because it was done for the 24 days and it was on limited Zoom platform. So if the long-term study along with randomized control trial with increased sample size, that will be showing more effect, or it can be effective for generalizing the effect as well.
Thank you, ma'am. Thank you for your presentation.
Yeah, thank you.
Thank you all for joining us today for this successful paper presentation session. We have seen some outstanding work and insightful discussions. And I want to extend my gratitude to all our presenters for the hard work and dedication. We appreciate everyone's participation and engagement throughout the session. Your questions and comments have truly enriched our experience. Now, I'm excited to announce the winners of today's presentation. We have one best oral paper presentation and one best e-poster presentation. And the winner is winner for e-poster presentation is Miss Savita Kohekar, ma'am. Congratulations, ma'am. And the best e-paper presentation is Miss Arohi Fernandez. Congratulations to you. We congratulate all the winners of today and we appreciate the hard work of all our presenters. Stay tuned. Thank you once again.
Good evening. Are you all here? Okay, so once again I thank all the participants of scientific research presentation. Your contribution added value to our national conference and also our delegates of conference gained knowledge through your scientific paper. So here we come to an end of the session. Now the delegates are requested to kindly fill the post-test as well as the feedback link which is there in your WhatsApp group. You can see the feedback link as well as the post-test. You have to fill it, otherwise you will not get the certificates. Please fill the feedback form and post it till the guest will arrive. Now I will announce the name of the colleges by. As I announce the names of the colleges, the participants please come forward. We'll have a photograph with the delegates. The first college, Harsh College of Nursing, Khamgaon. The participants who has come from Harsh College of Nursing, Khamgaon, please come forward. And I also request the guests and the HODs of the departments to please come for the photo session. Thank you so much. I request the participants from Saraswati College of Nursing, Amravati. The delegates from Saraswati College of Nursing, Amravati. I request the delegates from Satpura Nursing Institute, Shegao. We have delegates along with the faculty from Satpura Nursing Institute, Shegao. Next, I request the faculty and the students from Shivanjali College of Nursing, Ahmednagar. Shivanjali College of Nursing, Ahmednagar. Next, we have MVPS Jalgaon, Nashik. MVPS INE Jalgaon, Nashik. Next, we have Vision College of Nursing, Buldhana. Vision College of Nursing, Buldhana. Vision College of Nursing, Buldhana. Next, I call MSc faculties from Godavari College of Nursing. MSc students from Godavari College of Nursing. First year. MSc students first year from Godavari College of Nursing. And I also request the coordinator of first year MSc to please come forward. Coordinator and class teachers of MSc first year. Next, I invite MSc second year students from Godavari College of Nursing, along with the coordinator and class teacher. I also request the coordinator of MSc second year to kindly join. Next, I call faculty from Pandurang Patil College, Akola. Satpura Nursing College, Shegao. Faculty from Satpura Nursing College, Shegao. If anybody remaining for photograph can come forward. If any of the colleges are left out for photographs, can come forward. Mother Teresa College of Nursing, Nanded. Thank you, all of you. An event like this cannot happen overnight. The wheels started rolling weeks before. The ceremony was nothing short of spectacular. It was heartwarming to see so many smiling faces present from yesterday with us. Revealing in this new journey of opportunities to bring this event towards its conclusion, we believe a token of gratitude is in order. I now request Professor Jesindaya Ma'am, HOD of Community Health Nursing Department and NAC Coordinator of Godavari College of Nursing to express the gratitude by proposing the vote of thanks. Okay. Ladies and gentlemen, esteemed colleagues and distinguished guests, I am Professor Jacinthia, HOD, Community Health Nursing, and it's my honor to stand before you today to deliver the vote of thanks on behalf of Godavari College of Nursing as we conclude this remarkable national conference. Over the past 2 days, we have experienced a truly successful event filled with engaging discussions, insightful presentations, and valuable networking opportunities. As Nelson Mandela once said, it always seems impossible until it is done. Together, we have transformed our goals into reality, and for that, we are immensely grateful. I would like to express our gratitude to our President, Dr. Ullas Patel Sir, ex-Member of Parliament. His vision and guidance have been instrumental in shaping this conference. As he has said, education is the foundation upon which we build our future. His dedication to empowering the next generation is truly commendable. I would like to extend a heartfelt appreciation to our esteemed speakers. A special thanks to Dr. Jamra Rani Ma'am, Associate Professor at AIMS Kalyani, West Bengal, for leading the session on simulation-based education for clinical readiness. Your insight and expertise have provided us with valuable perspectives on enhancing clinical education, and we are grateful for your contribution. I would also like to express our gratitude to Dr. I. Clement Sir, Principal of Sparsh College of Nursing, Bengaluru, for his engaging presentation on evidence-based practice, influence on clinical. Your emphasis on integrating evidence-based practice into clinical training has enriched our understanding and will undoubtedly impact our future approaches. We are also thankful to Dr. Rita Lakani Ma'am, Head of the Clinical and Recognition at Ibagmak Adventures Private Limited, Mumbai, for her insightful discussion on emotional intelligence and burnout prevention. Your focus on mental well-being in clinical setting is vital for fostering a healthier work environment. A heartfelt thanks to Dr. Ravindra H.N. Sir, Dean of Parul Institute of Nursing, Vadodara, Gujarat, for his presentation on innovative leadership models shaping the future of clinical nursing practice. Your insight into leadership are crucial as we strive to advance nursing education and practice. We are grateful to Dr. Nesa Satyam Ma'am, Principal of Apollo College of Nursing, Chennai, for his valuable session on interdisciplinary approaches in nursing practice. Your perspective on collaboration across disciplines highlights the importance of team network in healthcare. Additionally, we appreciate Dr. Larissa Mata Sam, Principal of Lakshmi Memorial College of Nursing, Mangaluru, for her engaging presentation on a collaborative approach between nursing educators and clinical nurses. Your emphasis on collaboration will strengthen the ties between education and practice. A big thanks to Dr. Mohammad Hussain Sir, Member of Board of Examinations at MUHS and Vice Principal at Gokhale Educational Society, Nasik, for his informative session on quality assurance in nursing education with clinical guidelines. Your insights are essential for ensuring high standards in nursing education. Your all valuable insight have greatly enriched our conversations. In the words of Maya Angelou, nothing will work unless you do. Your dedication to sharing knowledge has inspired us all.
I also want to thank our panelists, Dr. Milind Kale sir, Principal, MES College of Nursing, Latur, Dr. Vishwanath Edbire sir, Member, BOS, Allies Vice Principal, MGM Mother Teresa College of Nursing, Chhatrapati Sambhaji Nagar, and Dr. Shiv Sharan Singh sir, Principal, Vishwaraj Institute of Nursing, Pune, and the moderator, Mr. Swapnil Rahane sir, Assistant Professor from Parul Institute of Nursing, for the thought-provoking contributions. Your diverse perspectives have engaged us to think critically and broaden our horizons. As Helen Keller wisely remarked, alone we can do so little. Together we can do so much. Your collaboration has been a fundamental part of our success. I would like to extend our deepest gratitude to our Dean, Dr. Prashant Solanki sir, for delivering a captivating keynote address. Your insight and expertise have set the tone for our conference, inspiring us all to think critically about the future of nursing education and practice. Your words have not only informed us, motivated, but also strive us for excellence in our respective fields. Thank you for sharing your valuable perspectives and being a guiding force in our discussions. A special thank goes to our principal, Professor Vishaka Ganveen ma'am, for her unwavering support and visionary leadership that played a crucial role in making this conference possible. We extend a heartfelt gratitude to Mr. Praveen Kole sir, Nursing Administrator, Godavari College of Nursing, for his unwavering moral support and tireless effort that contributed significantly to the success of our conference. Your exceptional leadership and commitment have inspired us all, fostering an environment where collaboration and innovation thrive. Thank you for being a guiding force in this journey. Now, let us take a moment to acknowledge the tremendous effort of our organizing committee. Your hard work and dedication have been vital to the success of this event, and we are truly grateful. Thank you to the registration committee for ensuring a smooth check-in process, and through the food committee, your thoughtful arrangements have kept us well fed and energized throughout the conference. We also appreciate the e-paper poster presentation committee for facilitating the innovative presentation and the cultural committee for adding creativity and vibrancy to our gathering. A big thanks to the welcoming committee whose warm greetings made every participant feel valued from the very beginning. I would also like to acknowledge the technical and sound engineering team and the stage arrangement team. Your expertise ensured that everything flowed seamlessly, allowing our speakers and participants to shine. We extend a heartfelt thanks to our sponsors and partners, Maharashtra University of Health Sciences, Nasik, and Maharashtra Nursing Council, Mumbai, and Jindra Foundation for the support. Your support reflects your commitment to our shared vision and has helped create a vibrant community. A special mention goes to our offline participants. Your presence has made this conference dynamic and engaging. Connecting face to face has allowed for deeper interactions and meaningful discussion. As Robert Collier says, success is the sum of small effort, repeated day in and day out. Participation has greatly contributed to our achievements. To our online participants, we appreciate your engagement and insight. Your involvement highlights the power of technology in bridging distance and connecting us well. Finally, I want to thank each and every one of you, both in person and online. Your questions and contributions have fostered a sense of community that we can forward. And we conclude, let us take with us the knowledge gained and the connections made. Thank you once again for your participation and support. Safe travels, and I look forward to see you at our next international conference. Thank you.
Thank you, ma'am, for your valuable words. Now I request the delegates from faculty as well as student, those who want to express their experience of this 2-day conference can come forward. Anybody from the participants, those who want to express their feelings, experiences of this 2-day conference, national conference.
Hello.
Nobody?
Check. Hello.
We need your valuable feedbacks.
Thank you so much all of you for inviting us for this very knowledgeable and valuable national conference. And when we are coming this college, this campus is very beautiful and very well developed and so beautiful. We are so lucky we are gathered here, and thank you so much.
Thank you so much for your insightful words. So by this we conclude the session and conclude this national conference. All the delegates can have your tea at the second floor, and those who have come from outside colleges can collect their certificates of national conference from the counter at the reception. And the delegates from our college, that is Godavari Foundation, will be receiving the certificates afterwards in order to minimize the inconvenience for the others. So outsiders can receive the certificates. One more participant wants to share something.
Thank you. First of all, a very good evening to everyone. My name is Vaishali Gavai and I am from Satpura Nursing Institute, Jalgaon. I want to thank to the Godavari Nursing Institute or college for holding the national conference. We share and enjoy a lot this conference. And thank you to all the speakers who educate us. We really enjoyed their sessions, and we look forward for the international conference now. And thank you so much again.
Thank you so much. Anybody else wants to share something?
Thank you, ma'am. Good evening, ma'am. I like this conference. Campus is so good, and this information will be really helpful in our future also. And I like to complete my MSc from this college.
Thank you so much. Anybody else?
Good evening, everyone. Myself, Mrunali Bhatkar from Akola. And I was very happy as soon as we got the message in the group that Godavari Institute is conducting a conference. So it was a very proud moment, and I'm very lucky that I could come here. And I would like to thank the Godavari Institute, especially Vishaka Madam and her entire team for the organizing this conference, and inviting all the knowledgeable persons who gave or who shared their the informative sessions with us. And as Madam said, that we have the abilities more than we think. So I think whatever we have gained from this conference, we will surely try to implement in the institutes. And yes, of course, quality comes when we take efforts. So it is our responsibility that we take efforts and we change. Yes, the session has ended, but I think it is a real start where we can develop whatever we have learned from this session. Thank you so much and congratulations.
Anybody would like to share something? Okay, thank you so much. So we'll stand for national anthem. Everybody is requested to stand for national anthem.
जनगण मन अधिनायक
The delegates and participants here are requested to keep 2 minutes silence in order to give Shraddhanjali to Ratan Tata, sir. Thank you so much. We'll stand for national anthem.
जनगण मन अधिनायक जय हे भारत भाग्य विधाता पंजाब सिंध गुजरात मराठा द्राविड़ उत्कल बंग विंध्य हिमाचल यमुना गंगा उज्ज्वल जलधि तरंग तव शुभ नामे जागे तव शुभ आशीष मांगे गाहे तव जय गाहे